know what happened. Okay.
When the beeps start falling in frequency, I will begin. You know, people don't have to turn off their video. I mean, it's not, if you would prefer it to be off, that's fine. But I know of some people who say that it kind of builds a little more community to keep the video running. But anyways, it's up to you. And I know some people are not dressed as well as they might want to be, or eating lunch or breakfast or whatever. Well, good. Why don't we go ahead and get started? I want to welcome everyone to a special edition of the DMICE Research Conference, which typically happens at the end of academic terms, because there are often students who are either defending proposals or defending theses or dissertations or giving their capstones or symposium or whatever. So we always have more than would just fit into once a week. So we schedule them at these slightly off times, which are probably easier to make these days because most of us are sitting at home. So anyways, today we're going to have a PhD dissertation proposal defense, and the purpose of a proposal defense is for the candidate to describe the work that they're doing for a larger audience, namely the department and anyone else who's attending our research conference. And it gives many different people an opportunity to respond to critique, even give suggestions before the student pursues their, in this case, dissertation, and same thing for a thesis, master's thesis proposal defense. So our speaker this morning is Mishra, who most of you know because she's been around the department for a couple years, and she's a PhD candidate. She's also a National Library of Medicine Fellow in the Health and Clinical Informatics major. Before she started our program, she was a certified clinical research professional and spent her time managing and coordinating clinical trials in oncology and bone marrow transplant at the Dornbecker Children's Hospital. She has 2 master's degrees, one in biotechnology from Banaras Hindu University in Varanasi, India, and also a master's of public health from the University of South Carolina. Her interests are in the secondary use of electronic health record data, in particular using that data to enhance the knowledge about diseases and effectiveness of treatments. Her current research interest, which she'll describe to us, is in exploring the effectiveness and unintended consequences of implementing clinical practice guidelines in the EHR. So she is defending her dissertation proposal. She will initially give us a presentation, and then there'll be time for question and answer, and then her dissertation advisory committee may wish to spend some additional time with her when she's done. So I'm going to turn the floor over to Meena.
Thank you, Dr. Hirsch. Lynn, can you take this and give me the privilege to share my?
I don't have host privileges at the moment.
Oh. Okay.
I wonder if Diane can.
Diane is the host. So.
Oh, okay.
Yes. How do I give Meena the rights to share, Lynn? Oh, there it goes.
Yeah, there it goes.
It's sharing.
Okay.
Okay.
Yeah, I was on a meeting yesterday, and there was quite a delay between the time the person clicked share and the time it showed up.
Sorry, that was not. Okay. Good morning, everyone. Thanks for being here for my proposal defense. So the topic of my research proposal is bridging the gaps between evidence and practice of assessing risk and addressing harms for adults on chronic opioid therapy. Essentially, I'll be looking and assessing system readiness and how it affects the task of risk assessment. The roadmap for my presentation will include the background, gaps from literature, my research framework, and the questions, methods, and analysis for each of my aims. I'll end with the deliverables and how they will add value to the current stage of affairs, and I'll finish my talk with the timeline. So the landscape of primary care is changing. Actually, the landscape of the healthcare is changing, essentially to address the quintuple aims of improved quality, improved outcomes, reduced cost, improved provider experience, and the most recent addition to these aims, the improved equity. There is a growing awareness that individual health is tied to social, environmental, and community determinants of health. The Affordable Care Act is based on this premise as a result of various reports that have come out of Institute of Medicine, now known as National Academy of Medicine. There is a move towards integrating primary care and public health to better support the patients, families, and the caregivers. So our PCPs, or the primary care providers, are the first contact and access to care for patients. Primary care visits make up about half of all physician office visits. This figure is based off of the National Ambulatory Medical Care Survey of 2016. About more than half of these primary care visits involve one or more chronic condition, and 1 in 5 of these visits involve 3 or more chronic conditions. And the scope of primary care practice is huge if we consider it by means of the number of ICD codes that are used in the primary care practice. Primary care providers use almost twice the number of ICD codes than other specialties. So we've already established how complex the primary care setting is and how complex the primary care setting population is. In addition, primary care physicians are experiencing burnout. According to the 2018 survey of America's physicians, 78% of the physicians report sometimes, often, or always experiencing the feeling of burnout. The two factors that are least satisfying about medicine for most physicians are the EHR design and interoperability and the regulatory and insurance requirements. More than half of the physicians feel that EHR reduces their efficiency. So if you take a minute to consider the Friedmans fundamental theorem of biomedical informatics, which states that a person assisted by an information resource is better than a person that acts unassisted, then we consider one of the three corollaries that accompanies this theorem, that the information resource should be informative, and in essence, the resource should provide a new information, and the information should be correct and actionable. So if we consider this theorem and the corollary, we arrive at the fact that the EHR as an information resource needs improvement to better assist primary care providers in their complex information needs. And what my research proposal tries to do is exactly that. I seek to develop a generalized pipeline to identify the information needs of primary care providers and information readiness of the information resource, in this case EHR, so that we can improve this information resource that the physicians have to deliver better care. And to develop this pipeline, I'm looking at the use case of PCPs doing risk assessment for their patients on chronic opioid therapy and using opioids. PCPs prescribe about half of all prescription opioids and manage most chronic pain patients. And the 2006 CDC guidelines calls and recommends PCPs to weigh the risk and benefit when prescribing opioids. So to look at more closely at some of the data about this epidemic and the prescription opioids role in this epidemic, about 21 to 29% of the patients who are prescribed opioids for chronic pain misuse them. 8 to 12% develop opioid use disorder or OUD. 4 to 6% who misuse transition to heroin, and about 80% of the people who use heroin first misuse prescription opioids. And OUD is associated with considerable morbidity and mortality, which lends itself to a huge economic burden. And the mortality rates for a person with OUD is 10 times higher than that of an average population. So risks from opioids, prescription opioids, can be reduced if we follow the guidelines by screening and monitoring patients for misuse, abuse, and opioid use disorder. These are the three categories of recommendation that CDC guidelines have. And I'm more specifically looking at the third category, which is assessing risk and addressing harm. So there are various risk factors for all the different opioid-related harms, the misuse, abuse, and OUD. And several of them are present in the guidelines themselves, like looking for patient's history of overdose, patient history of substance use disorder, patient being on a high dose of opioids. So the guidelines recommends to look into that when you're considering opioids for risk for overdose. There are also several risk factors from literature that suggest high risk for misuse, like family history of substance abuse or personal history of substance abuse, younger age, etc. So all these different opioid-related harms are associated with different risk concepts. If we look at the opioid use disorder in particular, it is a highly heterogeneous condition. The diagnosis of this disorder needs the patients to meet at least two of the 11 symptoms from 4 different concepts. And these concepts are impaired control, social impairment, risky use, and some pharmacological properties of tolerance and withdrawal. The OUD disorder actually ranges from mild to severe. And to get to the diagnosis, the providers often use screening tools, or they look into the EHR for certain aberrant drug-related behavior. Oftentimes, these ADRBs are unsystematically documented in structured notes. So if you look at the problem of chronic pain and addiction, they both have an underlying biopsychosocial context, which means that to address these problems, the physician needs to integrate multiple types of data, biological, psychological, social, and certain factors that act as a mediating factors to precipitate addiction. So if we look into literature, there are several gaps that suggest that the information needs of PCPs, there are gaps in understanding the information needs of the PCPs when they are assessing risk and addressing harm. So, for example, there is no one risk assessment tool that can guarantee accurate risk for any one patient. The lack of evidence about the role of ADRB in identifying problem opioid use is there, and there is also a lack of understanding about the role of social determinants in risk assessment and harm reduction. There are also gaps in the readiness of EHR to address the information needs of the PCPs. Identifying problem opioid has been difficult due to inconsistent problem opioid terminologies and variation in documentation practices. There's also inconsistent use and documentation of standardized screening tools, which adds to the EHR readiness level at the point of care. So my central hypothesis for the research study is that the current EHR system does not address information needs of PCPs to perform efficient and effective risk assessment at the point of care. And to do this, I am proposing this research framework. Under the AIM-1, I will identify the information needs by doing some literature review of the guidelines and peer-reviewed literature. The second part of my AIM-1 will encompass prioritizing these information needs by using the modified Delphi survey. AIM-2 will be to evaluate the information readiness. The data quality assessment of the high-rank concepts from AIM-1 will be assessed using a harmonized data quality framework. The AIM-3 will involve evaluating the impact of information readiness. So I will look at the performance of few clinically relevant measures and see how they perform in the current state of information readiness. So this is the question that I'm trying to answer as a part of my AIM-1. What are the high-ranking concepts for risk assessment? And so in order to address the question, I will be determining the high-ranking concepts. And the second question that I'm asking as a part of AIM-1 is, does the need for certain concepts change based on healthcare setting? And are we getting ready for that? Sorry, I hear somebody say something. Is there a question? So AIM-1 is the first part of AIM-1 is essentially a very exhaustive literature review. The steps would include conducting a search of guidelines and best practices out there, and also some peer-reviewed scientific literature from PubMed and Scopus. I have already done preliminary research and come up with 269 articles. I've used mesh terms for chronic pain, opioids, opioid-related risks and outcomes, and have a initial list of 269 articles that I'll be going through. I've developed my inclusion and exclusion criteria, basically looking at the articles that have a population that are adult and primary care physicians, conditions that include chronic, long-term, non-malignant pain, medications that are that include prescription opioids, and outcomes that are relevant for the study that I'm doing, all opioid-related outcomes of like misuse, abuse, addiction, overdose. And the objective of articles will also be considered. Basically, I'm looking at articles that will that are looking at risk factors or predictors for the above outcomes. The exclusion criteria would include any condition that includes palliative care, malignancy, hospice care, or cancer. And I'm including articles that are from USA and Canada, just because the guidelines for risk assessment of these countries are very similar. So already from preliminary research, I see that the four outcomes that physicians are tasked with monitoring monitoring in their care. They have several risk factors that overlap, but there are also several risk factors that are specific to these outcomes. And so this would be very, very helpful when I'm designing my survey. So second part of my aim one is essentially doing a modified Delphi survey to rank all the opioid risk concepts that I come across from literature review and talking to the stakeholders. So I will be developing and piloting the survey and identifying experts for my survey and administer at least 2 rounds of modified Delphi survey. The main goal of this aim one is to reach a consensus on most needed risk concepts to assess risk for patients on COT. COT is basically chronic opioid therapy for pain. So this is my modified Delphi process. The round one is basically the thesis stage in which I'm collecting and there's an exhaustive search, literature search for all the opioid risk concepts for risk assessment and harm reduction in primary care setting. The round two, so round one in a Delphi survey is essentially a qualitative survey to collect all the concepts, but I am modifying the Delphi process by doing the collection, by doing the literature review. The round two would be the first round of survey where I will use the survey to elicit the need for each risk concept, from very high to very low. And the round three is the synthesis stage of my modified Delphi process where the physicians or the participants of the Delphi survey would be asked to reevaluate their response for each concept. And so the purpose of this process is to arrive at a consensus how important a particular risk concept is for provider to assess risk for their patient population. So the most important part of the modified Delphi survey is defining the experts. And for the purpose of my Delphi survey, I am going to be recruiting physicians who routinely manage patients on opioids for chronic, non-malignant, non-end-of-life pain. In past studies, it appears that the experts being considered for this type of survey are who are seeing at least 4 or more patients of this type. And that's what I will use for defining my survey experts. My sample size would include a purposive sample of 30 experts, and the setting would be a diverse primary care setting, family medicine, internal medicine, women health center. And the purpose of using, including women health centers, there could be risk factors that are specific to gender, and women may have a slightly different risk factors than males. Basically, I'm trying to include rural and urban participants and participants from academic health center and federally qualified health center. The Delphi survey will use the REDCap, the most recent version that's at OHSU. All of my survey items will be closed Likert scale survey items from very low to very high, except for one. I will include one single open question to include any additional concept that I may have missed. So this is a sample of my modified Delphi survey. Basically, it shows all the, identified risk concepts and request providers when considering opioid prescription, how helpful they find these risk concepts at the point of care. And the last one on the sample is the box for providers to provide additional concepts that I may have missed. So this is essentially the analysis of my first round of Delphi survey, which would include doing a descriptive statistics for each of the risk concepts, doing the central measures, measures of central tendency and dispersion. And there will be an on the open question that I have on the survey, I will do a content analysis to determine if there are any new concepts that I can include with the second round of Delphi survey. The consensus definition for the risk concepts is if any of the risk concepts reach more than 75% of the participants rate that risk concept as high or very high, I will identify that a consensus has been reached for that risk concept. So this is how the structure of round 2 would look like. Basically, the descriptive statistics from round 1 for each of the concepts, together with the individual responses of each participant, will be shared. New concepts that arise from the qualitative response will also be shared, and the participants will be asked to reflect and reevaluate their responses. The analysis of round 2 survey would include the mean and consensus level for each risk concept, and the risk concepts will be ranked based on their mean score. The results from round 1 and round 2 will be compared using a paired t-test, and the results for different groups or the settings that I've included in my research study will be compared using appropriate parametric or non-parametric test. So rigor, reliability, and validity is a very important aspect of a mixed method study, and I will strive to maintain rigor by striving to have maintain a response rate of 70% of or more for each round. The reliability will be maintained by, I'm doing a very extensive, exhaustive upfront collection of concepts using peer-reviewed studies and input from stakeholders, and that will ensure reliability to some extent. Also, the very iterative study design of Delphi process also seeks to improve the reliability, especially since I'm seeking response from several experts as a part of my study design. The validity will be ensured by the quasi-anonymous study design. This reduces bias, and participants are less likely to be influenced by how their peers answer on any risk concept. And also including experts from various different settings increases the external validity of my findings. So this is, again, we approach the research framework. The aim 2 is what I'm going to address next, which is to evaluate the information readiness. And the way I'm going to do this is the question that I'm asking as a part of aim 2 is, are the high rank risk concepts that we identified from aim 1, are they easily available in EHR? And the ease of availability is the presence of a risk concept in a structured or discrete field is taken as a proxy for ease of availability. The second question that I'm trying to answer in aim 2 is, what is the quality of the risk concepts? So once we determine are they present in the structured and discrete field, what does the quality look like? Does the risk concept inform risk for the patients? There is a reach aim as a part of the aim 2. I would like to determine if the availability and quality of high rank risk concepts depend on patient characteristics. So the material that I am proposing to obtain is a de-identified data set from Research Data Warehouse of adult patients on opioids for non-malignant, non-end-of-life pain between January 2016 and December 2019. And I'm choosing that time point because 2016 is when the CDC guidelines came out. 2017, saw that guidelines being disseminated and implemented in the EHR. So that's the reason for choosing that specific time point. So I already have a strategy for the RDW to extract the initial cohort that I'm interested in, and this strategy was developed based on the guidance from the CDC document. Basically, I'm looking at patients over 18 years who are on opioids based on the national drug classification codes, and basically these patients need not have any of the ICD codes linked to malignancy. They shouldn't be on any medication that are not otherwise used in the outpatient setting, and they should meet the description of chronic opioid use, and the definition is again taken from the one recommended by the CDC. So at the end of this strategy, I hope to get my initial cohort of adult patients who are on chronic opioid therapy for non-malignant, non-end of life pain. So here is the method. In order for me to determine which of the high rank concepts are present in the structured field, I will do some informational interviews with the PCPs to determine which of the high rank concepts that are identified from AIM-1 exist in the structured or discrete field in the EHR. And so use that as a starting point for my AIM-2. These high rank concepts will be extracted from the RDW from the initial cohort that has been identified. So basically, this is showing the analysis for determining what proportion of the structured high rank concepts for all the high rank concepts that I identify in AIM-1, what proportion of those exist in a structured field, and of the high rank concepts that exist in the structured field, what proportion of the COT patients have those high rank concepts? And these are important information to have if we want to improve our EHR system. Again, the second part of my AIM-2 is determining the quality of these structured high rank concepts. In order to do so, I will do some manual chart review on random sample of patients in the de-identified data set. So I'm hoping to do a cohort, use the cohort discovery tool to get an initial sense of what my size of the de-identified data set would look like in order to determine the N for my random sample. And the quality dimensions that I will be looking at is completeness, correctness, and currency. So this is what I will be doing, how I'll be defining the completeness and correctness. I will define it based on Hogan and Wagner's method. Basically, they use the sensitivity metrics for completeness and the positive predictive value metrics for correctness or accuracy. And that's what I will be using for my high-rank structured concepts. The currency of the concept will be determined based on whether it falls within the required timeline according to the CDC guidelines or to inform the risk determination. So as I mentioned, I have one reach aim as a part of my AIM-2, which is to determine if the availability and the quality of high-risk concept depend on patient characteristics. And the reason I'm doing this is because it appears from literature that race and gender actually plays a bigger role in risk assessment activities being performed than actual risk factors. So this is to validate this finding so that we have a useful information and we can use that to address it in a later in practice. So I will be developing a multivariate regression model to determine if patient characteristics such as ethnicity, race, gender, income level, and insurance type predict data quality of high-ranked risk concepts. So at the end of AIM2, I hope to come up with a prioritization matrix of all my high-ranked risk concepts. And this will add to the value for future informatics projects. So again, this is my research framework again, and I will now proceed to AIM3, which is evaluating the impact of information readiness. And in order to do that, I will look at the performance of some clinically relevant quality measures. So in a recent study by Allen et al., it was determined, essentially by a modified Delphi process, that these five outcomes are important and clinically relevant when we are looking at clinical guidelines and its effect. And I will be using the results from the study and coming up with some measures to see how they perform based on the structured and unstructured data in EHR. So basically, I'll be looking at a risk-adjusted a measure that is based off of the risk-adjusted change in PEG score. I will also be looking at proportion of patients assessed for opioid abuse risk before initiating opioids, by whether an opioid risk tool or other screening tool were used to assess the risk, and what proportion of patients were assessed for aberrant drug-related behavior, like what proportion of patients had their PDMP checked or urine drug testing done, and the proportion of patients that signed a treatment agreement prior to opioid initiation. These are measures based off of recommendation in the CDC guidelines, and their performance based on the data that currently is housed in the EHR as a result of the care can throw some light as to, if you were to move towards, evaluating the effect of clinical guidelines, is the data in the EHR ready to address that? So again, in order to accomplish my AIM3, I'll be doing a chart review to extract clinical concepts for the 4 outcome measures using the structured and unstructured data. The performance and 95% confidence interval will be computed for each of the measures, and this will be used to as a basis for future projects to improve the EHR. So as a result of my research proposal, the deliverables specific deliverables that I have is a better understanding of the data needs and the availability at the point of care. I'm also hoping to develop a framework or a pipeline that looks at identifying the information needs and assessing information readiness, especially in context of a primary care setting, which is highly complex with highly complex data needs, information needs. I'm also coming up with a prioritization matrix that can inform future projects, like creating CDS or implementing ECQMs, or even developing a probabilistic risk stratification model. So my timeline looks a little busy, but I hope to stagger my proposal across the whole entire 2021, and hope to be done by the winter term of 2022. As planned, this is what the plan looks like. I have some cushion to in case something unexpected comes up, but this is my timeline. In the end, I would like to acknowledge my dissertation advisory committee, Stephen Bedrick, Nicole Weisskopf, Steve Kasakian and Dana Womack. The DMI faculty, which has been a huge help, Dr. Paul Gorman, Michelle Ribber, and Chris Hoekstra. The staff, Diane Doctor and Lynn Schwabe, and the students, Adam Rule and Ben Sanders, who provided me with valuable feedbacks. My mentors, Dr. Mary Pickett, who I've been pestering since I started, got interested in this project, and Jonathan Robbins, whom I have shadowed in the clinic. And I am extremely, extremely thankful to the National Library of Medicine for this opportunity. Thank you, and I'm ready for questions.
Great. There's a little bit of discussion going on in the chat. I don't know if you have any response to that, Meena, and then other people can either type things into the chat or unmute themselves and ask questions.
Okay, let's see. Does RDW include data from PDMP to capture prescription from outside of OHSU system? That's a good question.
Which I believe the PDMP is the system that's used to monitor certain types of drugs, including opioids, that patients may get at multiple locations. But I'm not the expert here.
Yeah, you're right. So PDMP is the Prescription Drug Monitoring Program, which is run by the state. Different authorities, state authorities run different states. So yes, the RDW data would not reflect if the patient acquired opioids from providers outside of the OHSU system, or any data that exists in PDMP will not be in the RDW system. So that's a good point. So Ben, do you have any additional concern if this thing is missed? I know the providers try to reconcile medications with their patients, and there is recommendation for them to check the PDMP and do that. But how often it will be done, that will be a limitation of the study.
Yeah, I just wanted to bring that up as a thought about it. I agree. Maybe that will be reflected in the way their workflows that they already do. But in terms of gathering data to document what's available to the providers, that might be missing, because as we know, many folks that are on the road towards inappropriate use will get prescriptions from many folks, and that's why the PDMP network has been established. But right. So I guess I would just ask you what would be the up or downside to that, to having access to that data.
Yeah, that's probably another study, but definitely that will be a limitation here. Okay, so I have PDMP SSP data is generally not captured in the local EHR.
Yeah, so Meena, there's been a lot of back and forth in the chat about what data do and do not end up in the RDW. And I think the overall take home with that is increasingly there are data from Care Everywhere that are flowing into our Epic background, but that's been fairly recent. I don't know how much that's going to impact your time period of interest. I'm also not sure off the top of my head if that means the data are also ending up in the RDW. And then Mary Pickett had another question or comment in the chat.
The hardest part of this may end up being validating the diagnosis of OUD. primary care doctors are not always confident about the diagnosis and not always right, and the patients often don't acknowledge they have OUD, even if the doctor believes them to. It would be helpful to think about working with addiction medicine specialists and work backwards from confirmed cases to chart makers flag that. Okay. Yeah, so Mary, what you are trying to get to is a project that would be a downstream from this. I'm certainly interested in making the diagnosis of OUD more amenable and doable for primary care providers. And if there is a probabilistic risk stratification model that I can come up with, I can look at this initial project as collecting all features that would go into that model. But that's something that I'm interested in will be downstream from this. Any other questions? Well, I did my capstone. It did not capture us. Okay. Yeah. I'm sorry if I missed anybody. I do not do very well when I read under pressure. So if I missed anybody, please, you're welcome to voice your concern.
I think those were the two main things that were being discussed in the chat while you were presenting.
Okay. I finished early. I had a lot of other slides, but I was not sure if I should present them all. So I left a lot of time for question and answer. Feel free to ask any.
Well, no, that's fine. You know, if there's any questions you want to ask of us, you know, otherwise we can give people 10 minutes of their day back.
Okay.
Okay, and I don't know if your committee wants to stick around, that you can decide that with them. But thank you, everyone, and we'll have another conference tomorrow at the usual time, so hope to see most of you then. Take care.